Hello, I'm Susan Nancaro. I'm the Chief Executive Officer of a company called Healthwork International, and we have three subsidiaries: AHP Workforce, the Allied Health Academy, and Healthwork Solutions. I'm also the founding chair of the Allied Health Assistant National Association in Australia, or AHANA. And it gives me great pleasure to give this presentation on optimising allied health assistance. I'd first like to give a little plug for AHANA. We've been established for just over 12 months, but gone live in the last month on the 1st of May. And we're taking membership to the Allied Health Assistant National Association. As far as we're aware, we are the first group in the world that has set up a national association for allied health assistants, and we have a self-regulation framework. So the model is that we are starting to set up the structures to support the quality and sustainability of the allied health assistant workforce in Australia. In this presentation, I'm going to touch on 4 issues, and we have a website where we've got more resources. The first is the question that we get, which is what's the relationship between allied health assistants and support workers? The second is how to identify tasks that are suitable for delegation, and I'll talk a little bit about the risk framework around that. The third is what is adequate supervision and mentoring, and finally, what are the issues facing allied health assistants working in different contexts, for example, regional and rural locations. So first of all, what is the difference between an allied health assistant and a support worker? These boundaries are becoming more and more blurred as the user pays models expand more, and service users are purchasing care directly from healthcare providers. But the difference that we have defined and that we recognise in AHANA is, first of all, allied health assistants really have a focus on reablement. They take their tasks under delegation from an allied health professional, and their tasks are generally specifically related to allied health work. And I guess importantly, they see that their roles are helping people transition through a stage of need or a health or a social issue. So it's not an ongoing model of care support, it's a short-term transition to move somewhere from one status of health and well-being to another status. We acknowledge that a number of support workers also work in this space and will do some tasks that might normally fall under the remit of an allied health assistant or an allied health professional. But our perception is that support workers are more involved in personal care. Not all of their roles are specific to allied health, so a lot of support worker work is involved in supporting individuals to do their day-to-day activities, not necessarily transition into a new phase of a health status. And this means that the care provided is often longer term rather than transitionary. We feel that there are opportunities for support workers to become allied health assistants and take on some more of those functions, and we believe that the AHANA regulation model can help to support that within a safe training and supported environment. The next issue I'd like to touch on is some of the challenges around the implementation of allied health assistance. And one of the most common questions we hear, and one of the biggest barriers to the effective use of allied health assistance, is what happens if I delegate to an allied health assistant and something goes wrong, or who carries the risk when I delegate? And it's such a murky area. And it's a complicated area, so I'm going to tease that out a little bit more. And secondly, what models of care can people use to introduce allied health assistance into their service, and how can you make those new roles cost effective? So first of all, who's responsible for the outcomes of care in a delegated workforce model? I'm going to touch on this, as I said, now, but we have a number of resources to support this on our website, which is ahpworkforce.com. This is an example of one of those articles, so if you don't pick everything up now, please feel free to go to our website and look at some of those resources. So when you're thinking about what should be delegated to an allied health assistant, there are a number of issues that should be considered. And these issues really are good practice when it comes to competency and credentialing of any kind of worker, not just allied health assistants, but keeping these principles in mind will set up a safe delegation framework. So the first point is to identify the task or skill that you think needs to be delegated. It could range from patient care activities or administrative tasks like scheduling appointments, but be really clear about what the task is. The second point that you're going to do is think about the complexity of the task and to a certain extent the risks of undertaking that task. So some tasks require more expertise or specialisation, whereas some can be performed by someone with fairly basic training and a simple instruction, or perhaps a protocol. The third point that you want to consider is the legal and regulatory parameters around any of the tasks that you might want to delegate. Now, this is a point that comes up a lot in the Australian healthcare environment. In reality, almost no scopes of practice are protected by regulation, which makes some of the boundaries here a little bit fuzzy. But what that means is that you actually have quite a lot of scope to delegate tasks as long as they are done within a safe practicing framework and a sound clinical governance framework. The things that are regulated tend to be high-risk tasks, so prescribing of medications and surgical tasks, but from an allied health perspective, almost nothing else is regulated. So this is almost a non-issue from an allied health assistant delegation perspective. I'm not sure that this is the right place for this one, but considering the patient needs, this should always be first and foremost in your decisions around delegation. But if you've done a risk assessment, you may make other decisions around the patient or client requirements about whether or not you're going to delegate a task. For instance, it might be appropriate for you to delegate a task, but you want to maintain continuity of care with that client or patient, so you make a decision not to. Or it might be something to do with the resource allocation or resource decisions, or perhaps even geographic or accessibility requirements. So obviously take into account the context in which you're considering the delegation and the needs of the patient. So there's not hard or fast rules. Point 5, is your allied health assistant competent to perform the task? What evidence do you have, either training, experience or certification, references, previous jobs, that the worker is competent to perform the task? What I would say is if there is evidence that someone is competent to perform the task, let them perform the task. You don't need to constantly re-evaluate that competence. But we do understand that there's often a lack of transparency around what determines that level of competency, so it can be difficult to judge whether or not someone is actually competent to do it. What I would say is if someone has a credential, like a training qualification, a Certificate 3, if you've seen them safely perform the task on the job, and if you have any other evidence that the person is safe to perform a role, then let them get on with it, but just do it within a safe framework. If they haven't previously performed a task, then you might want to provide them with some training or access to training, or just refresh their skills or even supervise them doing that task, but make sure you document that. Wrap some supervision and mentorship around that person, and I'll go into that in more detail in a moment, but look at ways to provide a safe framework to demonstrate that you've set up the principles and the environment that makes it safe for that allied health assistant to perform the job. This can help ensure that the task is performed safely and correctly, and it can also protect you and the allied health assistant. And finally, you need to monitor the outcomes and reassess as necessary. So after you've delegated the task, ensure that the task continues to be performed safely and efficiently. And this can be built into clinical records and follow up with the client. There are lots of different ways to perform that monitoring, but make sure you've got some sort of feedback loop to make sure that that task is being performed safely and effectively. I just want to touch here on the the legislative and regulatory environment that we're working within, because there's not one single framework. There are lots of different frameworks in which allied health assistant, in fact, all employment law operates within. And there are different things that we need to take into account. And I'm going to start from the outside of this diagram. If you are employing someone in any environment in Australia, you will be bound by employment law or legislation. And that'll cover things like equal opportunity, occupational health and safety, the Privacy Act, anti-discrimination, and obviously you'll need to comply with Fair Work requirements. So that's the overarching environment in which we're all operating in Australia. There may be other tiers, but the next level, everyone will be operating within a workplace environment, and the legal parameters or the policy parameters there that will guide the practice of your delegation will be employment contracts, employment awards, and any supporting workplace policies. And if someone is found to be in breach of some kind of practice, we will come back to your workplace framework for ensuring safety and governance and ensure that those things have been adhered to. When it gets down to the detailed relationship between the delegator, often the allied health practitioner, and an allied health assistant, you're normally working within a clinical governance framework. And those are all of the points that we've just touched on. Does the allied health assistant have appropriate training, supervision? Is there a risk management framework to ensure that they're performing those tasks safely? And do they have appropriate support to perform those tasks? Finally, and probably importantly, and this is the area that we get most concerned about, every individual clinician, every individual allied health practitioner, and every individual allied health assistant has a professional responsibility. If they're employed to do a job, they have a duty of care and they have to adhere to a code of conduct. If you're a member of a professional association, you will also have a series of professional guidelines that you'll have to adhere to. Almost all of those will be embodied in a code of conduct, particularly in Australia. If you're found to be in breach of that code of conduct, the regulator could take regulatory action, or if you're in a self-regulating association like AHANA, then we're able to remove you from that register and publicly state that you've been removed from that register. So I hope that helps to clarify some of the relationships. Most of what a supervisor will be looking at is that clinical governance framework and the professional responsibility and duty of care to make sure that a task is managed appropriately within that safe environment. So what are the principles of safe delegation? And I've got this from the perspective of an allied health assistant, and this really touches on the risk parameters that we've just talked about, and then I'll talk about it from the perspective of the allied health professional. If you're an allied health assistant, as I said, you have a duty of care to make sure that you operate within a code of conduct and within your own scope of practice. So that requires, first of all, that you understand the task that you're required to do. You also need to understand your scope of practice. And I think a lot of supervising allied health professionals worry about this. I've done a lot of research with allied health assistants and worked with allied health assistants, and my perception is that they are almost always aware of their scope of practice, what their boundaries are, and when they need to ask for help. If they're available, follow established protocols and guidelines. When you need support, ensure that you seek appropriate guidance and support from your supervisor, or it might be extra training, but don't do a task that you don't feel comfortable to do. Make sure you document everything and document as clearly as possible, and this is your protection in a lot of ways if anything does go wrong, which it is unlikely that it will. And finally, communicate effectively. Communicate effectively between the client and to the team that you're working with. It may often be important for you to communicate or advocate on behalf of your client to the service that you're working with. So that's something that you should document and also take to your wider team when appropriate. So the principles of safe delegation from the perspective of the allied health professional are very similar. From the perspective of the allied health professional, obviously you need to understand the task as well, assess the competency of the allied health assistant, and ensure that they are supported within an appropriate environment. Clear instructions, that you've got supervision and monitoring in place to ensure that they're performing the task in a safe environment. If you're delegating, document what you're delegating. If you've got protocols, make sure that you've got those in the documentation or that you mention them. And as we mentioned earlier, review and evaluate the delegation to make sure that it's appropriate. If there's some learning or a feedback cycle, make sure that you document that as well. If you operate within these principles, the risks are very low, and we know that because we have been in touch with an insurer. AHANA offers insurance, the premiums are quite low. The risks for allied health assistance and under delegation and within an allied health framework, if all of these governance processes are adhered to, the risks for allied health assistance are very low in clinical practice. Most state governments have supervision and delegation frameworks. This is the one from Victoria, and the Victorian government has also recently released some new delegation training programs online. Most other state governments have them, and I would urge you to take a look at those. We don't need to reinvent the wheel. And there are also a number of procedures developed by different employers. So look at things that are most likely to be relevant to the context in which you're working, but the principles are largely similar regardless of the context. The next point I want to touch on is adequate mentoring and supervision for allied health assistants. And a lot of this touches on the points that we've talked about in risk, because actually mentoring and supervision is about ensuring quality and managing risk and ensuring competence of the workers that you're working with. But there are really 10 principles that you need to think about to ensure that you're providing adequate mentoring and supervision. And again, most of the frameworks that you will look at will cover on these. They might be in different ways and different frames, but as long as they've got all of these points in them, you probably have a sound supervision and mentoring framework. Regular feedback is obviously an important part of mentoring supervision. Feedback needs to be constructive, and it should aim to improve your allied health assistance performance. And don't forget to highlight strengths as well as areas for improvement. Clear communication is key to any employment setting, but ensure that you clarify the roles and responsibilities and the expectations of your allied health assistant and how you're going to measure those. The third point is goal setting. Goals can be related to skill development, knowledge enhancements, or specific task achievement, and it's really important that these goals are SMART. That is specific, measurable, achievable, relevant, and time-bound. Fourth is skill development, and the mentor or supervisor should provide opportunities for the assistant to learn and apply new skills. This can be done through on-the-job training, through workshops, seminars, or e-learning modules. You should also encourage self-learning. We have a tendency to try to rely a lot on pedagogical learning, but andragogical learning, where people are self-directed, is valuable. And I think as we move into more and more competency-based education, self-learning is going to be more and more important. And this can be fostered using critical thinking, problem solving, and also the application of theoretical knowledge in practical situations. The next point is role modelling, and this is one of the most important aspects when you've got on-the-job training. The supervisor or mentor should act as a positive role model, demonstrating professionalism, ethical behaviour, empathy and effective communication, as well as appropriate delegation of tasks. Support and advocacy can be quite important by an allied health professional on behalf of their allied health assistant within a larger system. Often the assistant level workers don't have a voice because they don't belong to part of a clear or larger structure. So they often need the advocacy of more senior staff on their behalf. Ensure that you have regular check-ins. These should be regular between the mentor or supervisor and the allied health assistant, and these should provide opportunities for open discussion, problem solving and progress reviews. They can be formal or informal, but they do need to be available in a timely way. Maintaining an open and safe environment. It's really crucial that your assistant feels comfortable discussing challenges or issues that they might be facing, and a good mentor or supervisor will foster a safe and supportive environment that encourages open dialogue. And finally, as we've said previously, the mentoring or supervisory process should involve ongoing assessments. This might involve case reviews, skills assessments, or evaluations of patient interactions. Every allied health assistant is going to have different needs, so it's important that the mentor or supervisor can tailor their approach to the individual allied health assistant that they're working with. There are a number of different examples of ways that supervision can be implemented. I wrote a book with a number of chapters on allied health assistants, and it was interesting to look at the evolution of allied health assistants. We've always talked about allied health assistants needing to work under supervision. And in the early days of allied health assistants, that was perceived to mean having the allied health assistant in the same room as the allied health professional. As you'll know, in a disability setting, in an aged care setting, or most other settings, particularly in rural or remote environments, having the allied health professional in the same room as the allied health assistant is actually not feasible, and it's not an efficient use of the allied health assistant or the professional's time. So there are a number of different models that can be used for supervision, and I've just outlined some of them here. These are all legitimate models of supervision, and within AHANA we expect that allied health assistants work under a delegated framework, which means they need to have some kind of supervision from an allied health assistant. So what I really want to emphasise here is that does not necessarily mean on-site, hands-on supervision. Any of these models will be appropriate. So the first is direct on-site supervision, which is the supervisor being physically present while the allied health assistant performs their duties. It allows the supervisor to provide immediate feedback and guidance, and it can be important when the assistant is new, performing a complex task, or working with high-risk patients or clients. What we most commonly see, particularly in home-based models of care, is the allied health assistant is indirect or off-site supervision. So as the allied health assistant gains more skills and confidence, the supervisor generally doesn't need to be present at all times. They can provide supervision through regular meetings where they discuss the assistant's work, provide feedback, and plan for suitable future development. And the meetings can take place in any suitable environment. The models of care can be supported through protocols or guidance, or just verbal delegation, ideally documented. The third is joint sessions. So this might involve joint visiting for a certain number of cases or clients between the allied health professional and the allied health assistant. And this allows the supervisor to observe the assistant's interactions with the clients and their practical skills in a real-time setting. The next model is case conferences, and these are meetings where the allied health assistant, their supervisor, and sometimes other multidisciplinary members of a team discuss specific clients or cases. And it gives the opportunity for an allied health assistant to present their work, to discuss their decision-making processes, and receive feedback and advice. So this is can be a formal type of feedback. Obviously, we're all familiar with training workshops. Supervision can be provided through formal training sessions or workshops. They can focus on developing specific skills, discussing theoretical aspects of care, or they might address common challenges that the allied health assistants can face in the field. And the advantage of workshops is that you can provide a one supervisor to many allied health assistant model of supervision. Walkarounds, they're similar to joint sessions, but this is where the allied health assistant might the allied health professional might shadow the allied health assistant while they perform their duties. This tends to only work in institutional settings, but sometimes allied health professionals will go into a home or community environment with their allied health assistant. Performance reviews are normally a part of regular supervision, as we've discussed, where the supervisor and assistant discuss the assistant's overall performance, their achievement of goals, areas for improvement, and their future goals. And really, performance reviews need to be built into the entire supervision framework. The specific models of supervision can vary and are based on many factors, like the levels of experience and competence of the allied health assistant, the nature of their work, and the resources available for supervision, but also the context in which they're working. I briefly want to touch on the range of different models of care that can employ allied health assistants. Again, we've got an article about this on our website, ahpworkforce.com, so if you want to read more details, you'll find it here. But I guess reinforcing the different models of supervision, you can see that allied health assistants can be employed in lots of different ways. And I think the traditional models of supervision, where we've expected the allied health assistant to physically be close to or next to the allied health professional, have resulted in some cases in some fairly restricted thinking about the potential models of care. So the point of this is really to show a snapshot of some of the variety of the work that allied health assistants can do, and there's a lot more. We're really starting to collect some case studies on the variety of models of care. So telehealth services, we know that there are increasing models where allied health professionals support and supervise allied health assistants remotely, where the allied health assistant is actually delivering services to a client in situ while the allied health professional is supporting them. Alternatively, the allied health assistant can be delivering services directly through telehealth. Allied health assistants are often involved in group therapy sessions, and we commonly see this in communication groups, particularly with speech and language therapy groups. Health promotion and community outreach, digital health records and data analytics. So for instance, in speech pathology again, they might undertake dysphagia file reviews to identify clients in need of particular types of service or support. Remote patient monitoring, so that can be through the use of assistive and technical devices and monitoring of things like vital signs, risks of falls and so forth. The use of assistive technology and adaptive equipment, and this is becoming increasingly commonly used in areas like rehabilitation. Multidisciplinary care teams, and I've done a lot of work where allied health assistants have a multidisciplinary role and they are supervised by a multidisciplinary team who delegate a range of different tasks to the one worker. So you'll have actually multidisciplinary allied health assistants. Mobile health clinics, virtual reality and augmented reality in therapy. They can be used as patient navigators, and these are becoming increasingly necessary as the complexity of our health, ageing and disability systems become more complex. Allied health assistants can have specific skills to broker care and services for their clients. Administering specific clinical protocols, and we see this fairly commonly for things like falls prevention. Delivery of education, and again these are often protocol based. And administration, a lot of allied health assistant roles have actually come from initially providing administrative support in clinics. I've really just touched on some examples here, but do feel free to take a look at our article online, and if you've got other examples, we'd love to hear those. The last point I really want to touch on is the impact of the setting on different worker roles, and I'm specifically asked to talk about the impact of remote settings, but what I really want to touch on is the way that healthcare or disability settings, workplace settings effectively change the way that workers can do their tasks. And these apply to any kind of worker, not just allied health assistants, but generally we have a continuum from large teams in large organisations, and if we take the most acute example, that would be a tertiary hospital. At the other end of the spectrum, we've got smaller teams and more remote work, which often involves individuals going into individual client homes, and it may be in a rural and remote setting. When you've got a large team and a large organisation, you tend to have access to greater support and supervision, and that's more likely to be on-site and hands-on. The fact that you've got access to a greater team means that you can also have more specialisation of roles because there are other people around you that can do those tasks. Conversely, at the other end of the spectrum, when you go into a more remote setting, you have fewer support mechanisms. You also have less access to training, but that means there's more need for individual practitioners to take on multiple roles, multidisciplinary roles or generalist roles. Support and supervision is also more likely to be remote, and so you've got to take into account the clinical governance considerations that we've talked about earlier. There are really good opportunities for allied health assistants to work in these contexts because it means that one allied health assistant can take on the tasks delegated by a multidisciplinary team, but they need to have the appropriate clinical governance support around them. I'd like to end there. I'd just like to let you know about some work that we're doing through my company and for AHANA. We've just launched an Allied Health Academy, and through that we've launched a community of practice for allied health assistants, called the Allied Health Assistant Global CPD Collective. So this is a community of practice for allied health assistants where they can come and share their ideas and learning. Every week we upload a new case study for the allied health assistants to discuss. There'll be monthly webinars for allied health assistants to attend. The CPD Collective is free for AHANA members and $99 per year subscription basis for non-AHANA members. So we're really trying to build capacity and support for the allied health assistant workforce through this. So we'd love to see you there. And if you haven't joined already or you're not a member, we'd love to see you join AHANA. We have a lot of resources on the AHANA website, so please come and take a look. And I look forward to taking your questions. Thank you.